Well, thank you very much for giving me this opportunity this evening to talk to you about the work I'm doing. It's really lovely to see so many people here. Hopefully that's because they're interested in the topic and not because they've come here by mistake. So I'll try and keep you involved as we go along. First of all, I just want to introduce myself. So I have kind of two jobs. I work for Cancer Research UK as a senior research nurse, which means that I'm very involved in clinical trials. But I also work for the School of Nursing and Midwifery at the University of Dundee as a researcher, which means that whilst I can look at the clinical trials, I can also ask people who participate in trials or who receive the treatment from trials what it's actually like to experience that side of things. So it's actually a lovely combination of jobs that I've got there. Now, before I get into my talk completely, I just want to say a big thank you to a few people who were involved in this. The team, this is a team effort, and Dr. Ruth Dryden collected the data for me, Professor Mary Wells helped me with the analysis, Dr. Colin McCowan was very involved in helping me set up the study, and I'll talk a bit about his work and how that influenced what we did later. And we also have Professor Alistair Thompson who used to be at the working at Nine Wells as a surgeon and an oncologist, but has now gone off to warmer climes in Houston, Texas. Andrew Radley, who's a consultant in public health, and Mark Parsons, who's an NHS pharmacist. But the biggest thank you I want to give is to Pam Kelly, who's in the corner there, who really helped us to ground our study in real life. She kept our feet on the ground and our heads out of the clouds, which sometimes can happen with a researcher. So big thank you to Pam, and hopefully she'll recognise it. So I better get underway, or I could just stand here chatting like this all night. So first of all, there's sort of three sections to my talk really. I want to set the scene about breast cancer, then I want to talk really about the study that we did and what we found, and then maybe what the implications are for practice and for other research and how we're moving it forward. So in 2011 in the UK alone, 50,000 women were diagnosed with breast cancer. That means not just that it affected 50,000 women's lives, but it affected their families, their husbands, their partners, their friends. It has huge implications for people, so it's a very serious disease that we need to do something about. The good news is that 8 out of 10 of those women will survive beyond 5 years, 3/4 will survive beyond 10 years, and 2/3 will survive beyond 20 years. And part of the reason for that is through the work of research. We've got better at detecting earlier cancer, but we've also got better at identifying who's at more risk of developing breast cancer. So we know a lot more about the genetics and the family history. We're also improving treatments. There's a lot more that we can offer in the lines of sort of personalised medicine. So again, that links to the genetics of the disease and how best to treat it. Most of the women diagnosed with breast cancer, or around about 80%, will be what's called estrogen receptor positive. Now, what that means is that estrogen has a role in the breast cancer growing. Now, that sounds like bad news, but actually in some ways it's good news, because we have got a line of drugs that we can use to treat that, and they're the drugs I want to talk about tonight. For those women who are estrogen receptor negative, the drugs I'm talking about tonight aren't generally prescribed, and they may go on to have other treatment.